Hello and welcome to today's Feline Medicine webinar. My name is Lydia Morgan and I'm Commercial Manager here at Virtual Veterinary Specialists. At VVS, we're on a mission to increase the collaboration between first opinion vets and specialists. Our goal is to help you to approach every case with confidence. We empower vets to work together in real time alongside our specialists, allowing you to deliver referral level care to your patients in your own practice. See our specialist as an extension of your own clinical team. Our virtual support includes our brilliant VVS internal medicine service. Working together with Dr. Sarah Spencer and her fellow internal medicine specialist colleagues through our advice calls, you can discuss your case approach and collaborate together to successfully manage your cases in-house. Today, Dr. Sarah Spencer will be delivering the webinar, She's Just Not Right, Approach to the Vaguely Unwell, Inappetent and Lethargic Cat. And it's my great pleasure to introduce Sarah to you. Sarah graduated from the University of Bristol and initially spent some time in general practice before embarking on an internship and postgraduate certificate with the University of Nottingham at Dick White Referrals. She then returned to the University of Bristol for a specialist residency training. Sarah became an internal medicine ECVIM diploma in 2018 and worked at the RVC, where she supervised interns, residents, and participated in some undergraduate training. Sarah is currently doing a PhD at the RVC, investigating the role of aldosterone in feline chronic kidney disease. And we're really lucky to have Sarah on the VVS team, bringing her interest in feline medicine, as demonstrated today, as well as her care and compassion to the role. So with today's webinar, if you have any questions as we go through, please add them to the chat box and we'll finish up the presentation with a question and answer session at the end. So thank you for your time. And with that, I will hand over to Sarah for today's talk on the inappetent cat.
Thank you, Lydia. Thank you for the introduction. Thank you, everyone, for joining me this lunchtime. I hope you find the presentation useful. So let's dive into this cat that's just not right. So it's 11 a.m. on a grey Wednesday morning and Mrs. Smith arrives with her cat, worried that she's just not herself. And we've definitely all been there. And in fact, one study showed that inappetence is the third most common reason for cats presenting to their vets. And of course, the list of possible causes are endless, as are the tests that you could do, and unfortunately, the money that you could spend. So this is taken from the ISFM guidelines on the management of the inappetent cat. And as you can see here, we've got disorders of every body system that are listed, ranging from gastrointestinal to orthopedic. We've also got dietary and behavioural causes too, not to mention the effects of medication and polypharmacy. And this is particularly relevant for the treatment of these cases. I really urge you to take out this paper. It's got loads of really useful information. So first, let's look at what key information I try and get from the history. So it goes without saying it's important to obtain a full history, starting with your signalement, lifestyle, the diet, any preventative healthcare, previous or concurrent illnesses, then moving on to the clinical signs. And of course, there may not be any more specific clinical signs if the cat's just not right. In particular, it's important to pin down how long that this has been the case and whether or not there's been progression of any signs. And this can help you understand urgency. Has there been any recent changes at home? And in particular, has there been anything that could be contributing to cats' stress? For example, diet changes, new cats in the house. Has the cat undergone any tests so far, including at other practices? Similarly, any treatment? And if so, what effect did that treatment have? I think it's also important at this point to gauge things about the owner. So how concerned do they seem? And what are they willing to do today in terms of investigations and treatment? And in the nicest possible way, do you trust the owner's observations? And are they compliant? Next, of course, is your physical exam. And this is definitely the best guide as to what could be going on in these vague cases. And the best thing of all is it's free. So don't rush it and don't be afraid to concentrate on it alone. So perhaps take the cat away from the owner. You know, try not to think about that ever-growing list of clients in the waiting room. And I find it particularly useful to get someone else just to help you with restraint, even if the cat's very amenable, just so you can have a really good feel of everything you need to. It's also really important to re-examine anything you're unsure of. That might be at the kind of within the clinical exam or at a later date. So particular things to pay notice to would be demeanour, and I'm sure many of us have gut feelings when it comes to this. So this cat just seems really not bothered about being here, really flat or really dull. That could be a warning sign. Things like hydration status are important. What about the body, in particular the muscle condition, any cachexia? Are there any indicators of decompensation, so shock, any tachy or bradycardia? What's the pulse quality like? Are there any neurological abnormalities? Is there any pain anywhere? And if so, what is the degree of that pain? And of course, cats can be very good at hiding that. When you're doing your abdominal palpation, it's very easy to focus on just kind of comfort rather than systematically palpating the structures. So really try and spend some time on that. And finally, don't forget the hiding cat bite abscesses. I've been referred a couple of cases that we didn't really know what was going on, and actually we just found kind of cat bite abscesses or cellulitis in strange or kind of hard to detect places. So there are some subtle indicators of disease for each body system that I'm particularly looking for from my history and physical exam. And don't forget to kind of keep looking for these things on each visit if the cat is representing, and question closely, because things definitely could change. So I'm not going to read all these out, but I'll highlight a few. So for example, a subtle sign of anemia might be pica. We might see things like dysphonia, a change in meow that could indicate a laryngeal problem. I will say really focus on the respiratory effort in case there's some subtle dyspnea. So look at the, so look at the body wall. Is there any paradoxical respiratory pattern? Question about exercise intolerance. So is the cat kind of more than just lethargic? Is it struggling after going up the stairs, for example? Do a really prolonged cardiac and thoracic auscultation. So are the heart and lung sounds potentially dull in cases of pleural effusion? Have we got any arrhythmias or gallop sounds? And also something you could do within the physical exam would be a retinal exam, as this is very quick, non-invasive, and can be a real kind of indicator of systemic disease. So neurological signs in particular may be missed by the owner, but more obvious to us. So is the cat inappropriately dull, circling, or having any odd behaviours? Recent attention has been given to the subtle signs of osteoarthritis. So I'm sure you would have seen or used questionnaires to potentially discover that in your cases. I'll also draw your attention to signs of hepatic encephalopathy. So it's not common in cats, but portosystemic shunts do occur, and they often present, 1 to a few years old, unlike dogs. And changes that we might see might be things like tilism, odd behaviours, inappropriate mentation, blindness. And then in the gastrointestinal box, I would definitely be kind of looking for things like obviously weight loss and lymphadenopathy, thickened intestines, but also you might get things like bradycardia, so a high vagal tone can occur in gastrointestinal disease, and also less likely in respiratory and neurological disease. So what about red flags? When would I worry? So when would I be more keen to admit these cats for investigation and supportive treatment ASAP? So if the cat's very young or very old, if any other clinical signs that you've detected are severe and concerning, so we mentioned about dull demeanour, dehydration or shockiness, if the weight loss has been marked, or if the cat has poor muscle condition, certainly if the anorexia is total and it's getting on for kind of more than 2 days duration, and if the cat has previously had symptomatic treatment but failed to respond. There are also other factors. So if the owner is particularly worried, because obviously they know their cat best, If you can't 100% trust the owner, so if they're not very observant or reliable, so you're a bit worried about sending that cat home. If the owner's unable to medicate is obviously quite a biggie. And in all seriousness, if there's a weekend or holiday coming up, because it will be typical for you to send that cat home only for it to represent out of hours. So when would I wait? Again, if the owner was in agreement. So if the presentation is very acute or very chronic and the cat's signs are mild, if we think the history can explain the clinical signs, so for example, it's got some kind of wheezing and tachypnea, and recently there's been some building work at home, obviously if the signs were mild. If the cat was very alert, responsive in the exam, if its clinical exam was normal, if some appetite was still present, and if it previously has responded to symptomatic treatment, you might be more inclined to wait. Of course, if the owner is very reluctant to investigate, it's difficult to push it in those cases. It usually ends up coming back to haunt you if you do. And if there's more appropriate workup time another day, then again, I would say, postpone it for the following day where you've got more time in your diary. So say you've decided to sit tight for now, what symptomatic treatment could you consider? And this includes even if there are no symptoms other than the cat just being a bit down and a bit inappetent. So we could consider dietary modification. This is rarely wrong unless the cat has a known hypersensitivity. Meropitant and mirtazapine, we'll come on to those separately in a minute, but they can be useful. For corticosteroids, they might be an effective short-term pick-me-up for sure, and a positive response could be supportive of an inflammatory or an immune-mediated cause. However, of course, it might be detrimental if there's an infection present. Similarly, they're often used in combination with antibiotics, and if you see a response, you're not going to know which has worked. And for me, the real important thing is that they can mask any future diagnostics that you might do. So I might consider starting them if I think the diagnosis is warranted, so for example, IMHA or lymphoma, but after I've collected my samples and I'm waiting for results. So antibiotics I'll come on to again in a minute, but I find them most useful if you've got any clinical signs that are pointing towards a specific body system and therefore a likely pathogen. And of course, we should be remembering our antibiotic stewardship and considering that antibiotics can have side effects such as gastrointestinal or inappetence. We've got to think about that in these cases as well. Non-steroidals certainly could be useful if the cat's painful, obviously to be avoided if the cat's vomiting, has diarrhea, totally anorexic or dehydrated though. So for pain relief, you might be considering something along the opioid route like buprenorphine. I'll also say that omeprazole is commonly used in such cases. However, I would say to reserve it where you've got a suspicion of a gastritis or an esophagitis or even evidence of that. The reason being it's not a benign drug, and actually one of its more common side effects can include inappetence, which is the last thing that you want. And of course, when you're prescribing any of the symptomatic treatment, don't underestimate the effects of medicating on both the owner and the cat. We were talking about this just before the webinar, actually, in that, it can be a right pain to tablet, it can be stressful for the cat, and the owner might further contribute to the cat's signs. So meropitant, so it is hugely popular for non-specific signs and inappetence. And it's a selective neurokinin 1 receptor antagonist. So it mainly acts in the nucleus tractus solitarius centrally, and this is the final common pathway to vomiting. So it does block both peripheral and central stimulants. However, our use is assuming that it has a good anti-nausea effect and that nausea is contributing to inappetence. Some of the evidence, though, doesn't really support this. So a paper by Jessica Quimby in cats with CKD showed that while there was a decrease in vomiting in these cases, the cats that received mirtazapine didn't have any differences in their appetite scores, activity scores, or their weight. And then similarly, a study looking at mirtazapine given with pre-med to cats undergoing gastrointestinal or urogenital surgery showed no difference in appetite in those cases. Finally, a study investigating its use in cats who were given dexmedetomidine and morphine showed that being sick did reduce. However, the signs of nausea, such as drooling and lip smacking, did not differ between the groups. So I'm not saying don't use it, I'm just challenging our assumptions, and you could consider some alternatives if you think that nausea is a big issue in your case. One of those alternatives might be ondansetron. So this is a 5-HT3 serotonin antagonist and might be particularly useful in cats because cats have more of these receptors in the chemoreceptor trigger zone than dogs. However, it is off-label, it's expensive, and we have got evidence that it can reduce the severity of nausea and vomiting. However, its oral availability might not be as good as its parental availability. So if you have got the cat hospitalized, there is reason to use either subcutaneous or intravenous routes. So I mentioned before omeprazole, so omeprazole, ranitidine, metoclopramide, unfortunately, we don't have good evidence of their usefulness in controlling nausea, but certainly consider their use where the specific indications have been met. For example, if you think you've got some ileus, then metoclopramide may be useful. So when would I use an appetite stimulant and when would I not? So we've got 2 approved appetite stimulants in cats. We've got mirtazapine as Mirataz and also capmarilin as Allura, and I'll come on to those in a minute. So other proposed stimulants aren't proven or recommended. So I would definitely consider an appetite stimulant during our diagnostic workups, i.e. when the use is quite short term and our diagnosis is unknown. If we've got a behavioural or environmental cause for the inappetence, can definitely be useful as a supportive medication in acute and chronic disease, where cats are showing some interest in food, but their RER is insufficient. So the most classic would be our CKD cats. Definitely useful where we can't place the feeding tube for whatever reason, or you could try it before you move to that step. Or we could also use it when a feeding tube is in place, but again, we're wanting to encourage oral intake. And I have put on the list to support the intake of oral medications, but it's probably not ideal to be giving an appetite stimulant so that the cat can eat more tablets. But yeah, it's something else to think about. So I wouldn't use it in cats that are very, very critical, if they have ongoing vomiting or nausea, ileus. Obviously, if they're not able to prehend or ingest their food due to facial or neurological problems. We should be addressing things like pain management instead of kind of putting a plaster over the top with our appetite stimulants. Obviously, if we're giving oral appetite stimulants and the cat finds this very stressful, it could be detrimental. And then finally, if we are still working the cat up and therefore starving it regularly for sedations or anesthetics the next day, try not to use an appetite stimulant because then they might feel hungry, but they're also being starved. So it's a bit unfair. So talk a little bit about mirtazapine. So it has antiemetic properties, and we're probably all very familiar with using it in practice. There is no evidence of contraindications when it comes to liver or kidney disease, but we do recommend to reduce the dose or increase the dosing interval in these cases. So if we see behavioural side effects, so most commonly hyperexcitability, vocalization, tremors, then half the dose. But anecdotally, we do know that the long-term use appears to be safe. So now we've got the transdermal mirtazapine on the market, and it again appears to be safe and effective, certainly in CKD where it's been widely studied. You might see mild erythema on the site in about 10% of the cases. but interestingly, it potentially might be less effective as the oral version. So have a think about which you want to prescribe to your cat, and certainly if the cat is in the clinic and we're more used to medicating orally, then that might be a better way to give this drug. So moving on to capmarinelin. So this is a ghrelin receptor agonist, and so it's a directly appetite stimulant compound, but it also acts at growth hormone and insulin like growth factor 1 receptors. So it has been shown to be effective in D, and there are some potential adverse effects as well. In particular, transient bradycardia and hypotension have been documented. So I would say to avoid this if cat has kind of significant compromise systemically. So moving on to antibiotics as symptomatic therapy. It's very easy for me to tell you it's not recommended, but of course there are many times in practice where we'll prescribe this in cases like these cats. Certainly Pyrexia in particular doesn't, specify or rationalize their use particularly. But if I was to use a broad spectrum, first line choice of antibiotic would be amoxiclav. Forget the subcutaneous injections, I would just start them on oral, or an equivalent cephalosporin, and a 5-day course would seem appropriate. Doxycycline would probably be my second choice, especially if you think there might be a respiratory or a dental etiology. The difficulty is, of course, it needs to be given with food, so you have to think about that. And in terms of the proposed anti-inflammatory or immunomodulatory effect of doxycycline, is certainly not a sufficient reason to prescribe it alone. In veterinary medicine, this has only really been investigated in dogs with periodontal disease. There's no indication for convenia, unfortunately. So this should be reserved, obviously, for cases that have responded poorly to other antibiotics. And similarly with fluoroquinolones, we should be using those on susceptibility testing where possible. And when it comes to convenia, the duration of action is likely to be superfluous in these cats. So the cat might have failed to respond to your symptomatic therapy, or you might have seen some of these red flags that we discussed above, and this might have led to you to want to do some more diagnostic investigations. So this can definitely feel like a bit of a fishing expedition, and it's definitely tempting to do as many as you can and see what the results throw back to you. But we'll have a look about how you may be able to kind of target them down. So it obviously can get very expensive, and for this reason it's important to manage the owner's expectations from the outset. You certainly may need to repeat tests down the line, which I know can always be an awkward conversation. You might have to wait a long time to get results. Certainly owners tend to prefer treatment trials, but I think these are famously frustrating and they can be a false economy. It's quite useful to understand if referral might be an option at an early stage, again, because these cats can be quite kind of costly. Biopsies or kind of cytology are certainly really useful tests, but even these don't always provide the answer. So again, counselling the owner, that might be the case. And the way that I kind of think about it in terms of communication is don't be a black box. So a lot of the times I think owners get frustrated where they hand over their animal for the day, they know it's getting tests, and then at the end of the day they just kind of get handed this cat back, and then they're told that they're going to get a phone call with the results. So be transparent, try and explain everything that you're planning to do that day. So here I've got a suggested stratification of diagnostic tests that I might follow. So first round, I'd definitely be looking to do your basic database, so CBC, blood smear, biochemistry, including electrolytes, urinalysis, plus or minus culture. I'd be taking blood pressure if the cat was over 9, T4 similarly if the cat was older. You could do FELV, FIV snap test, and also I mentioned before a retinal exam as it's easy to do. Second round, if none of those tests can kind of point you in a more specific direction, I would definitely bring in imaging at that stage. So doing either kind of spot ultrasounds to look for free fluid in the thorax and abdomen, or even better, full abdominal ultrasound, and then thoracic imaging, either radiographs or CT. You could consider doing cytology at this point. So obviously specific sites if you've got abnormalities on your imaging, but also you could consider FNAing any accessible lymph nodes, and then the liver or spleen, again, using ultrasound. And then infectious disease testing might be coming in at this point. So this will depend on your body system that you think is affected, and I'll follow this up on the next couple of slides. Third round kind of tier of results, we're probably going to be looking to get some kind of tissue, so a biopsy for histopathology, plus or minus immunohistochemistry on top of that. Or if we're looking for lymphoma, we might be doing PAR, so PCR for antigen receptor rearrangements. So this is a clonality test that's looking to distinguish neoplastic from inflammatory lymphoid cells. And similarly, flow cytometry, which is immunophenotyping of white cells. I've also put here on the third round response to treatment or dietary trials. So there's a bit of a kind of full circle here in that you might end up reaching for a treatment trial if you feel you've exhausted your diagnostic investigations, or if you strongly suspect a certain disease. And then similarly, if you're thinking that it might be gastrointestinal, a hydrolyzed diet would be indicated. Oh yeah, and I will mention, again, I've got kind of arrows going back because it could be that you end up repeating some of these tests depending on how the CAT signs develop. So again, here by body system, I've listed which tests I might pursue depending on your clinical findings or any previous testing. So again, you can kind of refer back to these, but of note, you might want to be doing things like FELV provirus testing in anemic cases, thinking about bone marrow biopsies if you've got cytopenias or abnormal circulating cells. I will bring your attention to try and do a USG before fluids if you can. Consider SDMA if you think you might have an early CKD case. If you suspect oral disease, I think an exam under GA or sedation can be really, really useful, and be ready to perform cytology for any kind of lesions or masses that you may find. Pleural effusion can be really subtle in cats. So if you do find this, it can be very useful diagnostically. So things you could run on that would be cytology, culture, total proteins, and then consider feline coronavirus testing with PCR. Obviously, we can do pro-BNP on that fluid as well for cardiac disease. Infectious disease testing that I usually do on my BALs, so I would be doing cytology and culture, but also you could consider mycoplasma PCR, Bordetella PCR. And then for suspected cardiac disease, I think your TFAST, so your quick scans of the thorax, are really invaluable, as are measuring the left atrium to aortic ratio. But of course, a specialist echo is invaluable, and we're able to do this with VVS guidance. For neurological disease, I would say get the neurological exam form out, and this is like so invaluable when you're wanting to get all the information that you can, so you don't forget anything, and so you're able to pick up on anything subtle. Also might be useful to be doing kind of bile acid stimulation, looking for toxoplasma, whether that's with serology or PCRs. Don't know how many people in practice are doing CSF collection, but again, you can run infectious disease PCRs on those. For hepatic disease, I think cytology is the first step in many cases if you're concerned about neoplasia such as lymphoma. But biopsies are often needed for a diagnosis when it comes to cholangitis, cholangiohepatitis, and this might be true cut or with surgical biopsies. And bile aspirates are also really quite useful, and again, we'll talk about that a bit later. Other kind of less specific tests that you could be doing for infectious diseases would be mycobacterium testing on any lymph node tissue that you might have. We could think about alpha-1 acid glycoproteins to add to your puzzle if you're suspecting FIP. And then when it comes to gastrointestinal disease, I will be doing kind of cobalamin, folate, TLI, and then, you know, there are other things that I've listed there as well. So in my experience, what are the most useful tests in such cats? And bear in mind, this is based on a referral population. I think abdominal ultrasound is my absolute go-to, but also cytology of any effusions, again, lymph nodes, liver, spleen, bile is very useful. And then, you know, moving on to things like endoscopy, again, to get more kind of samples collected like tissue or cytology when it comes to bronchoscopy. Feline coronavirus PCR, again, is very useful, and you can do that on effusions or aspirates or tissue. Toxoplasma, yes, I think, you know, we do test for that. I think it's not something we see necessarily commonly, but testing for it can be a good rule out. And then similarly, another good rule out for me would be a TLI, so to rule out EPI. So remember, EPI in cats doesn't present the same way as it does in dogs, those classic dogs with diarrhea and weight loss and polyphagia. Cats are much more likely to be almost hyporexic with that condition. So my abdominal ultrasound 101, I'm not an imager. And ultimately, a full specialist ultrasound is likely to be useful in these cases. And of course, it's great that we can use VVS for that. But certainly, it's the most useful test for me. I'd really recommend Sally Griffin's. She's written a series in JFMS, if any of you have seen it. And there's loads of detail on what's normal and abnormal in ultrasound of the GI tract, pancreas, liver, and biliary system. So definitely check that out. So my things that I'm looking for would be to do our focused assessment, looking for fluid in the abdomen or thorax. So checking your 4 quadrants in the abdomen, which essentially is by the liver, by the bladder, and by both kidneys. Also do your TFAS. As I said, cats are very good at hiding a pleural effusion. When it comes to the GI tract, of course, a normal ultrasound doesn't exclude pathology, especially if you're chronic enteropathies, so small cell lymphomas and inflammatory bowel disease. But one uncommon change that you might see, not uncommon change, sorry, is thickening of the muscularis layer, but with preservation of the wall layering. And this in both IBD and small cell lymphoma. Are there any signs of obstruction? Or any masses? Would X-ray kind of help you interpret that? And then similarly, if mass lesions or free abdominal fluid is seen, definitely consider FNA, and I would usually get consent for FNA before we do the ultrasound, and similarly for sedation if the ultrasound is conscious. So lymphadenopathy, yes, if it's present, you may again want to do cytology of that. What about acute pancreatitis? Well, up to 80% of cases do have changes on ultrasound, but again, that can be quite a kind of operator-dependent thing to be able to detect. But we might see things like hyperechoic fat, hypoechoic tissue, thickening of the pancreas. You might see common bile duct dilation, abdominal effusions. And interestingly, ultrasound changes are not seemingly associated with prognosis in cats, whereas the extent of increase in the PLI is. When it comes to the liver and the spleen, are there any MASH lesions or generalized changes? I usually, I always check platelet count before aspirating the liver. Some people would also check their clotting times, but I usually only do if there's clinical concern of a coagulopathy, or if there's any other hepatic function markers that are abnormal. And then coming on to cholecysticentesis. So things to look for with regards to the gallbladder might be enlargement, wall thickening, sludge, and these changes can indicate neutrophilic cholangitis. And actually in cats, sludge occurs less commonly as an incidental finding than in dogs. So you might want to consider aspirating the gallbladder, and this might seem daunting, but actually studies have shown it to be quite minimally invasive and safe. So when you do this, it's recommended to go transhepatic, so through the liver, and also to perform complete drainage when you do it. Finally, when I look at the kidneys, are there any changes consistent with CKD, any pyrexia that might be indicative of pyelonephritis, or proximal ureteral dilation that might be indicative of an obstruction? And again, if the obstruction is unilateral, the cats might not be azotemic, and so their signs might be quite vague in those cases. So what, in my experience, are the most common diagnoses in these vague cats? And again, this is very much a referral population. But I look back at the cases that I've seen, and I would say lymphoma is unfortunately very common. Also really common is chronic enteropathy, cholangiohepatitis, and pancreatitis. FIP, again, is a biggie. Used to be a very sad finding, but obviously now we have treatments available. It's less of a death sentence. And as I've mentioned, pleural effusions, more common than you may think, oral neoplasias. So yeah, in my experience, we might be looking at some of these diagnoses, but time will often be the key. So waiting for clinical signs or diagnostic test abnormalities to develop. So a little note about teeth. In my experience, dental disease is rarely the cause for inappetence or anorexia. But I appreciate in primary practice, it may be more common. So it can be quite kind of costly and a little bit risky in some cases to presume that dental disease is the problem and then proceeding to general anaesthetic. However, a good thing about the general anaesthetic is you can combine it with other investigations, and it allows a full oral assessment for any masses or, having a look at the caudal pharynx. Again, post-dental hyperexia is kind of the last thing you want when you're trying to treat your anorexic cats. So ensure that you've got an adequate analgesia on board, and consider complications like retained roots if the cat remains inappetent. And it may be useful, if suitable, to consider a non-steroidal trial if you suspect dental disease before proceeding to surgery. I also want to touch a little bit on pyrexia, especially cats with so-called pyrexia of unknown origin, or PUO. So full disclosure, this data is taken from a study I published on cats that were referred with pyrexia. So not all were PUOs, some did have a diagnosis at the time of referral. But as you can see from the graph, infectious is the most common category, followed by inflammatory and then neoplastic. Unsurprisingly, cats with neoplasia were older, those with infectious disease were younger. And again, probably because it was a referral population, FIP was the single most common diagnosis. What I will say is that actually most of the diagnoses tended to be unusual or early presentations of relatively common diseases. And actually sometimes cats just got better despite what we did. So it's always important to remember. So other diagnoses that we found are listed here. So particularly interesting maybe that pancreatitis and sterile peritonitis were the most common inflammatory diseases that we saw. And then when it came to neoplasia, no surprise, lymphoma was number one. Pulmonary carcinoma was second, again, because this is something that's probably quite occult in terms of how the cat may present. And this paper, I found that the most useful tests were abdominal ultrasound, cytology, and histopathology, but also infectious disease testing was particularly useful, usually as a rule out. And then about 15% of the cases actually had no diagnosis at the end of their investigations, but interestingly, this wasn't associated with a bad outcome, which is good news. So I think we'll talk a little bit more about pancreatitis, because I think this is, again, a common reason why these cats might present to us. And I urge you to look at the 2021 consensus of pancreatitis. So it's interesting that they say that most evidence was in the area of diagnosis, and actually there's little evidence on the management, and this is really frustrating. Here's a list of the most common clinical signs. So lots of these won't be a surprise to you, but do note that tachypnea and dyspnea is on the list, and this occurs in about 1/3 of cases due to a combination of possible causes. So in terms of our diagnosis, it's usually by ultrasound in my hands when I have a imager available, plus or minus using PLR or DGGR lipase in combination. Good thing about the ultrasound is that you can also look for comorbidities of the gastrointestinal tract, liver and gallbladder. In terms of our SPEC PLI, so the PPV, which is the positive predictive value, is really quite high. So that's the likelihood that an individual with a positive test truly has the disease. Whereas the negative predictive value, which is the converse, is significantly lower. So I think an abnormal SPEC PLI does likely indicate pancreatitis, but the test can't be used to rule it out. In terms of our management recommendations, they are really extrapolated from humans and dogs, or kind of expert opinion. And there are no magic wands, obviously, otherwise we'd all be using that in practice. So very much supportive, symptomatic, managing complications, managing any comorbidities, using fluids to restore normovolemia. So my choice would be Hartmann's plus potassium chloride supplementation. You might want to be using those appetite stimulants and the antiemetics that we talked about earlier, potentially prokinetics, and metoclopramide has good evidence when it's used as a constant rate infusion. Definitely being proactive with our nutrition and feeding tube placement, and I'll come on to that at the end of the talk. And then analgesia, paramount. So only about 1/3 of cats will show pain on the clinical exam. My choice would definitely be to use an opioid. Our evidence for gabapentin and tramadol is really quite poor for cats. I always measure cobalamin in these cases and supplement it if it's low. There has been some buzz about the use of fresh frozen plasma, as it contains alpha-2 macroglobulin, which is a scavenger protein for activated protease. However, we don't have evidence yet that there's benefit in people or dogs. And so I only use it if the case is coagulopathic, i.e. pretty much, unfortunately, in DIC. Similarly, there's no evidence for antibiotics unless you've got bacterial complications like abscessation or concurrent infections, or if, of course, things like your CBC or your clinical picture is suggesting that the cat might be septic. Again, there's no current evidence for corticosteroids. Anecdotally, a lot of people avoid high-fat diets. I think that's a good idea, but it doesn't necessarily mean that we have to be pushing for a low-fat diet in these cases. Again, we haven't got good evidence of that. And then if you're more interested in the use of potentially immunosuppressants in chronic pancreatitis, there's a good discussion of this in the consensus statement. So one study showed that these findings were more frequent in non-survivors, so our negative prognostic indicators. And I'll particularly draw you to the finding that persistent anorexia during hospitalization was associated with a bad outcome. So we'll come on to feeding next. And make of it what you will, but antibiotics were more frequently administered to survivors. So now I want to discuss a little bit on the management of inappetence. So there are lots of reasons why cats won't eat in hospital that you'll be familiar with, obviously, as cat-friendly vets. But I find it very, very stressful when you have an inpatient that doesn't eat. So what category strategies can we employ? Again, I'm not going to read all these out. A lot of these are taken from the Taylor ISFM guidelines. But it all comes down to kind of being quiet, gentle, predictable and calm, creating a really nice environment for the cat. So preparing well for any procedures so that there's not a lot of activity around your handling. You know, consider things like owner visits away from the ward where they could be encouraging them to eat. Asking the owner about the cat's food habits. Does it prefer to eat alone or in company? Make sure the cat can move away from the food and take it away at regular intervals as well. Avoid our fixation on prescription diets in hospitalized cats just while we're trying to get the appetite going, unless, of course, you think a hydrolyzed diet is particularly important in your GI cases. And I think this was a really nice thing to say, is that aim for multiple positive interactions for every one we're handling as for a procedure, so that your cat becomes your friend. So could it be time to place a feeding tube? Well, obviously this will come down to things like the cat's temperament, owner preferences and finances, but definitely be looking to do this if the cat is eating less than 2/3 of its RER for 3 days or more, especially if that's accompanied with weight loss. So in anticipating reduced food intake, we could also proactively place a feeding tube. For example, if the cat's having major surgery or chemotherapy, it might help with your oral medication compliance. Certainly long-term, placing an O tube might be useful for that. And of course, if the cat is physically unable to eat, if it's got kind of facial injuries, it can be useful. But which should we be reaching for? The nasogastric tube or the esophageal feeding tube? So I really love nasogastric feeding tubes. I think they're very easy to place. You can teach your nurses to do it. And they're especially important for short-term use in your inpatients. They're very cheap, they're quick to place. You could do it out of hours if needed. Good for your critical patients, as we don't need general anaesthetic. And I think they're good if you're particularly suspicious that your cat is about to eat. So if it's close to the voluntary food intake. In most cases, conscious placement is tolerated, but obviously there are many cats that that's not the case. So it's good where you're not planning a general anaesthetic. They are more prone to blocking than your O tubes, and they're not suitable for non-liquid medication or non-liquid diets. We tend not to use them if the cat's got kind of upper respiratory tract signs like cat flu cases, or if they've got reduced mentation. And some cats are absolute masters at removing them. They'll do that within a second of you placing it, frustratingly. But you just need to take really good care when you kind of attach it to the cat's face. So you can see in that picture, there's tape that's securing it to the cat, and you just make sure it's out of the cat's eye line. And in some cases, it can prevent the cat from eating. So again, you might want to be using kind of soft collars or supervised time without the collars to encourage the cat to eat with it in place. O tubes, so certainly where longer term or more reliable tube feeding is needed, we can use thicker diets, and we're more likely to be able to medicate with tablets down the tube. Certainly going to be the tube of choice if you've got facial or nasal disease, and can be really good for surgical cases where we've got an intense post-op period as well. I also put on the list when inappetence is the only thing keeping the cat in. So your cat is otherwise, recovered from whatever was going on. It's bright, it's happy, it's alert, but it just won't eat. It can be useful to place an O tube in these cases so that you can get the cat home if the owner is able to manage that tube at home. Again, I don't know how many of you place these in practice. It can be a little bit daunting when you place the first few times, but it's easy with practice and help. There are some major complications. They're rare, but they can be serious, so always warn your owner. And they do require more maintenance than the NG tubes, and in particular, stoma infections are not uncommon. So finally, refeeding syndrome. This is something I thought I'd just touch on, given that we're talking about anorexia. And this is something that I think has brought in the rationale, which is why we stage our assisted nutrition when we start feeding the cat. So normally we'll be introduce food at 1/3 RER, then 2/3 RER the next day, and so on. So really interestingly, a study over 6 years in 4 clinics identified just 11 cats with refeeding syndrome. So it can be life-threatening when it occurs. You get things like hypophosphatemia, liver and kidney damage. But actually all these cats were missing for more than 3 weeks, and actually most for more than 6 weeks. So these are cats that have been anorexic or hyperexic for a really, really long period of time. So practically speaking, I think we're probably over worried about it or just very good at preventing it. So I don't think we need to be, so cautious when we're reinstigating our nutrition in these cases. So on that note, thank you very much for listening, and I would be very happy to answer any questions. And I will say, if anyone can't access any articles or references, just let the team at VVS know and I can get those over to you.
Thank you, Sarah. That was really brilliant. We've got a few questions coming in the chat box for you. And so please feel free to pop that in the question and answer box, the chat box, and we can have a look. I just wondered if a practice is unfamiliar with placing O tubes and kind of management. Could you recommend any good resources for placing and then also nursing care and management care afterwards?
Yeah, so again, the Taylor reference, the ISFM guidelines, they go through tube placement. They've got really nice pictures of how to do that. And then also there's a BSAVA manual by Sev Tasker. Again, that's got all you need to know about placing NG tubes and O tubes as well. What I find is if you're going to be sending cats home with O tubes is to get kind of an owner resource, whether that's your own instructions that you've written, or again, if there's ready-made resources available, just something that they can follow, because it can be a bit daunting when you kind of go do all this with an O tube.
Fantastic. We had a question, I think it was earlier in the talk, you were talking about starting patients with oral coamoxiclav rather than injectable. Just wondering if you'd be able to expand.
That's a really good question. Thank you for that question. So when I was in general practice, I used to use subcutaneous antibiotics, definitely. But when I then went into kind of specialist training and referral hospitals, it was suddenly like everyone was like, don't do that, because I think we know that a lot of the times that injection is just kind of sitting in the skin. In particular, if you've got a dehydrated cat or one with poor body condition. And I'm sure we've also all seen kind of injection site reactions and even abscesses associated with those antibiotics. So I think if you want to get your antibiotic on board quickly, then start with oral, because we know that's immediately going to be available to the cat. Obviously, the advantage of injection is that that's one less thing that the owner has to worry about for 24 hours while it's on board. So if that's the case, give the first oral antibiotic in the consult if you can, and then at least the owner's got a little bit of a head start. And then if you do want to use parenteral antibiotics in an inpatient, again, I would just be reaching for the intravenous route, because we know that's just going to be so much more optimal.
Brilliant, thank you. That's really, really helpful. And again, in terms of the kind of feeding the inappetent patient in the practice, obviously it's quite sometimes difficult because everyone has within a clinical team has a different approach. Do you have any good does the same article cover that for kind of nursing considerations for the inappetent cats and maybe communicating that within the team? Because I know kind of food on the nose is something you quite commonly see, and it's a difficult one to try and exactly gently persuade people that maybe that isn't the best approach.
Yeah, I think what it comes down to is, like I said in the slide, it's so stressful when you've got an inpatient, especially a cat for some reason. The other thing that sometimes we're worried about is hepatic lipidosis, which actually I didn't go into. So that's another reason to be proactive with our nutrition. So yeah, I think a lot of places now are cat friendly, and so you've got guidelines there. I would refer to ISFM again, and nurses again. I'm sure there are really good nursing kind of references if you want to get your nurses on board with regards to how to get these cat eating. But yeah, a good ACA, a good nurse that's really kind of focused on that task can be invaluable. Definitely.
And knowing where people's strengths are as well. If you've got an appetent cat and someone is really good at getting them eating, get them in. Perfect. Well, from our end, I don't think there's any other questions that have come through. Just, I suppose, do you have a specific, just one question that's come through? You say being proactive with nutrition. how soon would you go to tubing a patient? Do you have like a timeline in your head that you vaguely use, or is it so patient dependent?
I think obviously it's always depending on the case, but I do have this kind of like 2-3 days, I start getting twitchy. I start to think about planning that tube placement. So sometimes that 2-3 days has happened with the cat already at home, and therefore I'm going to be thinking about placing an NG tube, you know, within 12-24 hours of the cat being admitted. If that's happening, you know, later, I would do a bit more of a stepwise. So, you know, try a really good intensive 24 hours of encouraging oral intake, then thinking about the NG tube. And then if for whatever reason the NG tube doesn't work out, or the cat remains inappetent, or if you're going to do a GA and the owner's happy for a no tube anyway, then yeah, within kind of a couple of days, I'd be looking to place that O tube if we've got absolutely zero interest in food. And in particular, if you think that the cat's got something quite severe going on, that you're not that close to finding out what it is, if that makes sense. Obviously, if you think you're a bit closer to finding your answer and starting treatment, you might hang back a little bit on placing a feeding tube.
And do you have any top tips for securing an NG tube? Because that was always a tricky one with bits of
for me, sutures. So forget
okay.
staples, suture. Again, cats usually tolerate that beautifully, conscious. It's the least of their worries when you're putting something up their nose to put a couple of skin sutures in. So a couple of ways that you could do it, either across the cheek, and so some people like to do it that way, and then other people go up the bridge of the nose.
Great, that's really helpful. And if you're sending home with a symptomatic trial treatment, how soon before you'd want to see an effect, provided they're not getting worse, of course?
Another really good question, and you're already covering yourself to make sure that they're not getting worse. That's always what I say to the owners. Obviously, if they get worse, please come back. So I would be looking again, kind of 1 or 2 days if the cat is totally inappetent. But I would say if you've got kind of something bacterial, you'd be hoping your antibiotics would start to kick in by then. And then if you're using your appetite stimulants or, you know, antiemetics, those again should work really quite quickly. But if at any point you've got those red flags, or if at any point you've, you know, exceeding that time for total anorexia, then just see them back.
And would you use subcutaneous fluids for at-home supportive treatment?
I think it has its place. Certainly, you know, the setting that we usually use it in would be our CKD cats, where we think we know the reason for the inappetence. I think if the cat is actually dehydrated, you're much better off admitting it to put it on fluids. I think, again, it's a bit of not a last resort, but it'd be something I would do that if the owner just was flat out refusing that I'm not going to have this cat admitted, it can potentially tide the cat over for a bit longer. I will just say care, even with subcutaneous fluids, if you've got any concern about cardiac disease, that it can cause overload, or if you've got a small patient, just be careful with the amount that you're using as well.
Fantastic. Thank you, Sarah. I think that's all of our questions answered. If anyone wants to work with Sarah and discuss feline cases or any internal medicine cases, Sarah works with us every Thursday morning at VVS, so she's available for advice calls and support with your clinical cases. So please do get in touch. You can find a referral form on our website, www.vvs.vet. And I'm sure, as you can see from today, Sarah has a huge wealth of knowledge that she's really keen to share with you all, and it's exciting to work together on these cases and collaborate, and hopefully lead to great outcomes for the patient. So thank you, Sarah, for that really brilliant webinar. Thank you everyone for coming along in your lunchtime. I hope you managed to catch some food and drink before the rest of the day, and we hope to work with you soon. So thank you everyone, and we look forward to working with you. Thanks, Sarah.
Thank you. Have a good day.